Hello everyone and welcome to my YouTube channel. The topic for today's discussion is acute respiratory distress syndrome. So ARDS is any acute injury to lung which will result in the release of inflammatory mediators, which will in turn causes increased capillary permeability and will lead to pulmonary edema, which is non-cardiogenic, and it often accompanied by multiple organ failure. So this is the Berlin definition of ARDS. It is always acute in onset within 1 week of clinical insult or worsening respiratory status. There should be bilateral infiltrates on chest X-ray without alternative explanation, example effusion, collapse or nodule. There should be pulmonary edema which is non-cardiogenic, that is not explained by fluid overload or congestive heart failure. In ARDS, the pulmonary capillary wedge pressure is less than 18 mm of mercury. However, in cardiogenic pulmonary edema, the pulmonary capillary wedge pressure is always more than 18 mm of mercury. There should be hypoxemia, that is partial pressure of oxygen to inspired air fraction ratio is less than 300 mm of mercury. So according to this ratio, we can divide the ARDS into 3 different forms. Example, mild ARDS is if the partial pressure of oxygen to FiO2 ratio is 300 to 200, and if it's in 200 to 100 then it's moderate ARDS, and if it's less than 100 it is severe ARDS. What is FiO2? It is the fraction of inspired oxygen. So for example, if on room air you are taking 21% of oxygen, then the FiO2 will be 0.21. It is always expressed as a decimal or a fraction. This is X-ray of severe ARDS with bilateral infiltrates and pulmonary edema. So massive intrapulmonary shunting is the key pathophysiology in ARDS. It is due to widespread atelectasis and surfactant dysfunction. So despite giving 100% oxygen to the patient, there will be no improvement and it will have persistent hypoxemia. So it requires high PEEP to prop open the airways. There will be decreased pulmonary compliance, which will lead to increased work of breathing, and there will be increased dead space due to obstruction and destruction of pulmonary capillary bed, and the patient will also have low vital capacity and low functional residual capacity. This is ARDS. You can see that there is the fluid in the alveoli which is blocking the gaseous exchange. So the causes of ARDS is either the direct insult to the lung from pneumonia, which is the most common cause, or aspiration, inhalational injury, near drowning, or lung contusion. Or it can be indirect injury from sepsis, shock, disseminated intravascular coagulation, pancreatitis, trauma, example multiple fractures, transfusion related acute lung injury. No treatment is proven to reverse ARDS, so you have to treat the underlying cause and give supportive therapy. So you have to give respiratory support as well as circulatory support and other drugs like steroids. So for respiratory support, patient needs continuous positive pressure ventilation with 40 to 60% oxygen, but most patients need mechanical ventilation. And then the indications of mechanical ventilations are if the partial pressure of oxygen is less than 62 mm of mercury, and if the partial pressure of carbon dioxide is more than 45 mm of mercury. So these are some settings which should be done on the ventilator. That is, you have to keep low tidal volume and maintain it to 6 ml per kg. You have to maintain a plateau pressure of less than or equal to 30 centimeter of water, and FiO2 should be kept less than 60% because high levels are toxic to lungs. And positive and expiratory pressure, that is PEEP, is used when the patient is undergoing mechanical ventilation to try to decrease FiO2. So for circulatory support, we need to do an appropriate fluid management. The target central venous pressure should be kept 4 to 6 cm of water in non-oliguric and normotensive patient. BNP levels should be used to guide about the use of diuresis. So if BNP is more than 200, then you need to diurese the patient, and the target urine output should be kept in between 4.5 to 9 ml per kg per hour for 3 hours. And this has shown to decrease the time to extubation. The paralysis should be considered if patient's PaO2 to FiO2 ratio is less than 150, that is, the patient is in moderate ARDS. And the agent used is cisatracurium, which is a neuromuscular blocking agent, and it is given for 48 hours and it decreases the mortality. The role of steroid is controversial, and it depends upon the time of administration as well. So if it is taken within 72 hours, it will decrease the mortality and increase the ICU free days. However, if it is taken between 7 to 13 days, it will not have any effect on mortality rate, but it will increase ICU free days. On 14th day to more than 14 days, it will increase the mortality rate, so it should be avoided. Inhaled nitric oxide can be used, but it has no mortality benefit. However, it can increase partial pressure of oxygen to FiO2 ratio. Same goes with inhaled prostacyclin. Prone ventilation increases pressure of oxygen, but it has no mortality benefit. High frequency oscillatory ventilation has no benefit. In fact, it will possibly harm the patient, so it should be avoided. Lung recruitment therapy: apply CPAP on 40 to 45 centimeter of water for at least 2 minutes to recruit lung. Then increase PEEP to maintain. So that's the end of the lecture. I hope you learned something from it. If you do, please like my video and share it with your friends, and please subscribe to my channel so that I get motivation to make further videos. And thank you so much for watching.